senye Peko subi pura hey Halbu arito bebe Awi yemante ame Awe ruko senye Peko subi pura hey Halbu arito bebe Awi yemante ame Awe ruko senye Peko subi pura hey Halbu arito bebe Awi yemante ame Awe ruko senye Peko subi pura hey Halbu arito bebe Awi yemante ame Awe ruko senye Peko subi pura hey Halbu arito bebe Awi yemante ame Awe ruko senye Peko subi pura hey Halbu arito bebe Awe ruko senye Peko subi pura hey Halbu arito bebe To bebe tai sarambi per veture Senye awi anyanduva pura hey To petanye epote de yurupe Hapuka vupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuke la Emiliano ta ipuke la Yambay Yahamino nyondive Yero khape Torbu ape yahe sape ko Awi yemante ame Aweruko senye Toiko subi pura hey Halbu arito bebe Awi yemante ame Aweruko senye Toiko subi pura hey Halbu arito bebe Awi yemante ame
Yase hakwaraku Dobu aveima Okanyin boraku Doje reima Tapere Mewe katumbeke Te quiere o yo quiere Yahamon burube Yase hakwaraku Dobu aveima Okanyin boraku Doje reima Tapere Mewe katumbeke Te quiere o yo quiere
Awi
Yahamon
yemante ame
burube
Aweruko senye Peko subi pura hey Halbu arito bebe Awi yemante ame Aweruko senye Peko subi pura hey Halbu arito bebe Awi yemante ame Aweruko senye Peko subi pura hey Halbu arito bebe Awi yemante ame Aweruko senye Peko subi pura hey Halbu arito bebe Awi yemante ame Aweruko senye Peko subi pura hey Halbu arito bebe Awi yemante ame Aweruko senye Peko subi pura hey Halbu arito bebe Aweruko senye Peko subi pura hey Halbu arito bebe To bebe tai sarambi per veture Senye awi anyanduva pura hey To petanye epote de yurupe Hapuka vupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuke la Emiliano ta ipuke la Yambay Yahamino nyondive Yero khape Torbu ape ya hesape koe Aguille mantiame Agüeru kosenye Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeru kosenye Toiko subi pura hey Albu arito bebé Aguille mantiame
Ya se acuaraku Dobu aveima O kanyin boraku Doje veima Tapere Me hueca tunde que Te quiere o yo quiere Ya jamón burbe Ya se acuaraku Dobu aveima O kanyin boraku Doje veima Tapere Me hueca tunde que Te quiere o yo quiere Ya jamón
Aguille mantiame
burbe
Agüeru kosenye Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeru kosenye Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeru kosenye Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeru kosenye Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeru kosenye Toiko subi pura hey
O kanyin
arito bebé Aguille mantiame Agüeru kosenye Toiko subi pura hey
O kanyin
arito bebé
Doje veima
Agüeru kosenye Toiko subi pura hey Albu arito bebé To bebé taisarambi pebeture Senye agui anyanduba pura hey To petanye epote de yurupe Apuka bupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuque la Emiliano ta ipuque la Yambay Yahamino nyondive Yero khape Torbu ape ya hesape koe Aguille mantiame Agüeru kosenye Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeru kosenye Toiko subi pura hey Albu arito bebé Aguille mantiame
Ya se acuaraku Dobu aveima O kanyin boraku Doje veima Tapere Me hueca tunde que Te quiere o yo quiere Ya jamón burbe Ya se acuaraku Dobu aveima O kanyin boraku Doje veima Tapere Me hueca tunde que Te quiere o yo quiere Ya jamón
Aguille mantiame
burbe
Agüeru kosenye Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeru kosenye Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeru kosenye Toiko subi pura hey Albu arito To bebe tai sarambi perveture Senye agui anyanduva pura hei To petanye epote de yurupe Hapuka vupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuke la Emiliano ta ipuke la Yambay Yahamino nyondive Yero khape Torbu ape yahe sape ko Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame
Ya sea cuaraku Dolu aveima O cañen boraku Doye reima Tapere Me hueca tunde que Te quiere o yo quiere Ya jamón bube Ya sea cuaraku Doble aveima O cañen boraku Doye reima Tapere Me hueca tunde que Te quiere o yo quiere Ya jamón
Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe To bebe tai sarambi perveture Senye agui anyanduva pura hei To petanye epote de yurupe Hapuka vupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuke la Emiliano ta ipuke la Yambay Yahamino nyondive Yero khape Torbu ape yahe sape ko Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeru kosenye Toiko subi pura hei Albu arito bebe Aguille mantiame
Ya sea cuaraku Doble aveima O cañen boraku Doye reima Tapere Me hueca tunde que Te quiere o yo quiere Ya jamón bube
subi pura hey, halv arito bebé, awi llevante a me, abueluco señe, rico subi pura hey, halv arito bebé, awi llevante a me, abueluco señe, rico subi pura hey, halv arito bebé, awi llevante a me, abueluco señe, rico subi pura hey, halv arito bebé, awi llevante a me, abueluco señe, rico subi pura hey, halv arito bebé, awi llevante a me, abueluco señe, rico subi pura hey, halv arito bebé, llevante a me, abueluco señe, rico subi pura hey, halv arito bebé, pura hey. To bebé tai sarambi perveture, señe agui añandu va pura hey. To petanye epote de yurupe, apoka vupe se añua. Rei potaro e gerurente, paisagina Paraguay, paipuque la Emiliano ta ipuque la Yambay, Yajamino ñondive, yero que hape, torbe ape, yaje sape koe, agui yemante ame, agüeruco señe, toiko subi pura hey, halv arito bebé, agui yemante ame, agüeruco señe, toiko subi pura hey, halv arito bebé, agui yemante ame.
Yasina kwarahu dola veima o kanyimboraku dola veima tapere me hueca tunde que te quiere o yo quiere ya jamón burbe. Ya se acuarahu dola veima o kanyimboraku dola veima tapere me hueca tunde que te quiere o yo quiere ya
Agui
jamón
yemante ame,
burbe.
agüeruco señe, toiko subi pura hey, halv arito bebé, agui yemante ame, agüeruco señe, toiko subi pura hey, halv arito bebé, agui yemante ame, agüeruco señe, toiko subi pura hey, halv arito bebé, agui yemante ame, agüeruco señe, toiko subi pura hey, halv arito bebé, agui yemante ame, agüeruco señe, toiko subi pura hey, halv arito bebé, agui yemante ame, agüeruco señe, toiko subi pura hey, halv arito bebé, yemante ame, agüeruco señe, toiko subi pura hey, halv arito bebé, pura hey. To bebé tai sarambi perveture, señe agui añandu va pura hey. To petanye epote de yurupe, apoka vupe se añua. Rei potaro e gerurente, paisagina Paraguay, paipuque la Emiliano ta ipuque la Yambay, Yajamino ñondive, yero que hape, torbe ape, pellaje sape koe Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame
Yase hakwaraku Dolu aveima Okanyin boraku Donde reima Tapere Behueca tunde que Te quiere o yo quiere Ya jamón burbe Ya se acuaraku Dobu aveima O canyen boraku Doye ureima Tapere Behueca tunde que Te quiere o yo quiere Ya jamón
Aguille mantiame
burbe
Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé To bebé taisarambi pelveture Señe agui añanduva pura hey To putanye epote de yurupe Apoka vupe se añua Rei potaro e yerurente Peisajina Paraguay Paipuque la Emiliano ta ipuque la Yambay Yahamino nyondive Yero khape Torbu ape yahe sape koe Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame
Ya se acuaraku Dolu aveima O canyen boraku Donde reima Tapere Behueca tunde que Te quiere o yo quiere Ya jamón burbe Ya se acuaraku Dobu aveima O canyen boraku Doye ureima Tapere Behueca tunde que Te quiere o yo quiere Ya jamón
Aguille mantiame
burbe
Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille mantiame Agüeruko señe Toiko subi pura hey Albu arito bebé Aguille To bebe tai sarambi perbeture Senyi agui anyanduva pura hei To petanye epote de yurupe Hapuka vupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuke la Emiliano ta ipuke la Yambay Yahamino nyondive yero khape Torbu ape yahe sape ko Aguille mantiame Agüeruko senye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeruko senye Toiko subi pura hei Albu arito bebe Aguille mantiame
Yase hakwaraku Dobu aveima Okanyum boraku Doje ureima Tapere Me hueca tundeke Te quiere o yo quiere Yahamon burube Yase hakwaraku Dobu aveima Okanyum boraku Doje ureima Tapere Me hueca tundeke Te quiere o yo quiere Yahamon
Aguille mantiame
burube
Agüeruko senye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeruko senye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeruko senye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeruko senye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeruko senye Toiko subi pura hei Albu arito bebe Aguille mantiame Agüeruko senye Toiko subi pura hei Albu arito bebe To bebe tai sarambi perbeture Senyi agui anyanduva pura hei To petanye epote de yurupe Hapuka vupe se anyua Rei potaro e gerurente Peisajina Paraguay Paipuke la Emiliano ta ipuke la Yambay Yahamino nyondive yero khape Torbu ape yahe sape ko Aguille mantiame Agüeruko senye Toiko subi
Buenos días a todos. Realmente es un gran honor para la División de Medicina Cardiovascular dar inicio a este ciclo de charlas de educación médica continua con un gran amigo del Paraguay, que es el doctor Allison, de la Mayo Clinic, Rochester, Minnesota. Él es profesor de la Facultad de Medicina de la Mayo Clinic y director del programa de Medicina Deportiva y Ejercicio en la Mayo Clinic. El profesor Allison ha compartido con nosotros varios congresos acá en Paraguay y siempre se ha mostrado muy presto a poder colaborar y ayudarnos en todo lo que respecta a cardiología en el Paraguay. Y en este caso nos va a hablar sobre un tema muy importante, el cual es los ejercicios, las pruebas de esfuerzo y todas las particularidades y perlas, como él bien lo define, que nos pueden ayudar a un mejor diagnóstico y, por supuesto, tratamiento del paciente. Good morning, Professor Thomas Allison.
Good morning. Buenos dias.
Hello? Okay. On behalf of the Cardiovascular Department of the National University of Asunción, I would like to thank you for sharing with us your time. I know you are on vacation, and we really appreciate you taking this time out of your vacation to share with us this very thrilling and important topic, which is the stress testing. And also, you will show us all the pearls that you have collected along your career. We are really very interested and very happy to have you here, Professor Allison, of course, supporting our cardiology fellow programs and all our students here are very eagerly waiting for you, friend Professor.
Hi, yes. All right, so I say good morning to everyone, and I'm sharing some of my pearls. In 43 years of practice, I've collected a big string of pearls, but we'll have some of the best ones today. And I want to say hello to all my good friends in Paraguay. I won't mention everyone because I'm afraid I leave one out. So I'll just say hello to everyone at once, okay? And yes, I am on vacation, but my grandchildren are in school right now, so I'm free. But you see, no necktie, no white shirt, no lab coat. So I am on vacation. So let's share this. Let's share the screen, okay?
Yeah. Okay.
And we'll get started. Everybody hears me all right, I hope. So I'm going to talk to you about stress testing and try to teach you something about stress testing in the 21st century by some case examples. Now, I have to show this slide, okay, since this was produced at Mayo, and I have no disclosures. So let's look at the first pearl, and we'll call this pearl beyond the ST segment. So this is a 67-year-old male. He has no prior history of coronary disease. He presents with a 5-week history of exertional dyspnea. It sounds like it might be an equivalent of angina because it occurs only at moderate to high levels of exercise. The severity is proportional to the exercise level, and it resolves very quickly. He has underlying substrate for coronary artery disease with hyperlipidemia, hypertension, impaired fasting glucose, erectile dysfunction. He's being treated with atorvastatin, lisinopril, aspirin, and sildenafil. His cardiovascular exam is normal, except he has a high BMI. When we predict his risk of 10-year risk of coronary event, it's in the intermediate range, 13.7%. Now, as we look at his resting ECG, I'll give you a minute to think about it. Then I will tell you that, at least to my eyes, it's unremarkable. His exercise ECG, I also think is unremarkable. If we look at V5, where we see most of the ischemia on a stress test, this is all clearly upsloping. There's a little bit of ST depression in lead 1, but you can see that's really from the baseline drifting, and it's not a consistent. This is very beat to beat. So we would have to call this test negative. Now, but when we perform a stress test, we're doing more than just performing a stress ECG and coming up with a positive or negative result. Functional capacity is very important. Symptoms, the Duke score, which takes functional capacity, symptoms, and the ST segment into account, the blood pressure response, and we just published a paper in the last 2 weeks on this, I'll show you, the chronotropic index, how well does the heart rate increase, and the heart rate recovery, how well does it come down after the test. So functional capacity, if we look at Framingham risk score group from less than 5% to greater than 20%, and we take an average functional capacity, we see that the risk, in this case, it was 8-year all-cause mortality, increased from 1.2% up to 10.8% as the Framingham risk score increased. But as the functional capacity decreased, let's take this intermediate risk patient, 2.3% mortality if the performance on the treadmill was 110% or better, average performance, and poor performance, you see a 10-fold increase in risk, very similar to the increase in risk we see with increasing Framingham risk score. So functional capacity, very important. The Duke score, we take the treadmill time on the Bruce protocol or equivalent on another protocol, subtract 5 times the maximum ST deviation and 4 times the angina index. And survival based on the Duke score, 3 categories: low risk, intermediate, and high risk. You see survival goes from 99% in 4 years to only 79% in 4 years with the Duke score. Here's the chronotropic index. We take the heart rate reserve, the maximum heart rate minus the resting heart rate, and divide it by the predicted values, which we have developed in our laboratory. A value less than 0.8 is considered abnormal. And as you see, the higher the chronotropic index, the lower the risk. As the chronotropic index decreases, risk goes up. Based on a large cohort of patients, no baseline cardiovascular disease, and over 12-year follow-up. Same data for heart rate recovery. We take the heart rate at peak, subtract the heart rate at 1 minute during active recovery. If it's less than or equal to 12, it's abnormal, 13 or more, normal. So as the heart rate recovery increases, risk goes down. These are patients on beta blockers, patients not on beta blockers. So although the chronotropic index is affected by beta blocker, the heart rate recovery is not. And you see, when we get above 13, there still may be a little decrease in risk, but below 13, a big increase in risk. Now, this paper is just published online. My fellow Yazan Asaf, and I'm the corresponding author on this. And as you see, a low blood pressure compared to every other category. When the blood pressure is less than the 10th percentile for age, we see a greatly increased risk of a reduced survival. And for our patient, male, 67 years old, the 10th percentile here at the bottom would be about 160 millimeters of mercury. So the blood pressure for a man that age should reach at least 160 during the stress test. Okay, let's see how he did. Now, he had no significant ST changes, but his exercise time was only 76% of predicted. He had angina, and it not only was present on the test, but it limited his exercise. His Duke score, minus 1.5. Chronotropic index, remember, should be at least 0.8. His was 0.68. Heart rate recovery, at least 13. His was 8. Blood pressure only went up 12 millimeters of mercury and did not achieve the 160 that we were looking for. So now we think, does this patient have coronary disease? If we look at the ECG only, we say very unlikely. If we look at the prognostic indices, we say it's very likely. So some might say a toss-up, but I'm saying very likely. And let's look at his cath.
Yeah.
Okay. You can see lesions in the LAD, right? Agree?
Yeah, very clearly.
Very clearly. And RCA, what do you think about the RCA?
It's closed.
Let me, mid RCA?
Yeah. Severe, middle and distal.
Yeah, middle and really gets thread-like down here, doesn't it? Okay. Now, if we look at the guidelines for revascularization, we can see intermediate risk, even with no anti-anginal therapy, two-vessel disease, including the proximal LAD, revascularization is appropriate. And so this patient went on and had drug-eluting stent in the proximal and mid-LAD and in the RCA, and has had no events, no angina. And now we look at his performance after revascularization and cardiac rehabilitation. Very important part is the cardiac rehabilitation. Here were the initial results and the 12-week results. So you see exercise capacity normalized, angina is gone, Duke score dramatically improved, chronotropic index and heart rate recovery are both normalized, and the blood pressure response now is much better. Okay, so summary, the first pearl, the exercise test is more than just a stress ECG. Performance, symptoms, hemodynamic responses must also be taken into account in interpreting the test and determining the appropriate course of action. Here's my second pearl, beyond 10 METs. Okay, you know, a MET is a measurement of exercise capacity. One MET is 3.5 milliliters of oxygen per kilogram of body weight per minute, which is what is needed to sit quietly in a chair. Okay, so this is a 62-year-old man sent for a screening exercise test. Now, we'll talk a little bit about whether that was appropriate or not. He's physically active, and he reports no symptoms, but his father and his brother both had myocardial infarctions in their 50s. His cardiac exam is normal. His 10-year risk is in that intermediate range, but largely because of age. Now, we look at his resting electrocardiogram. I'll give you a minute to look at this and make your judgment. Now, when I look at this resting electrocardiogram, I see, of course, it's sinus rhythm with normal axis, but I see an early repolarization in the inferolateral leads, and I'm thinking maybe there's a little bit of athletic heart here. Maybe this guy's pretty fit. And I think this might interfere with my interpretation of the test because we're measuring the ST segments at either 80 milliseconds beyond the J point or 100 milliseconds beyond the nadir of the S wave. And I'm not sure I see a J point or an S wave here. If I were reading this test, I'd probably use V4 rather than V5 as my analysis lead. Let's look at his prognostic signs. So exercise time, really good. No angina. He has an excellent Duke score. His heart rate goes up extremely well. His heart rate recovers well, and he has a normal blood pressure response. But as you see, as I predicted, he has some ECG changes. Now, what do these mean? We'll see. We have less change in V4. In the inferolateral leads, we have a lot of ST change, but within 15 seconds, you see it's largely all upsloping and disappeared. So now I'm going to challenge you and say, does this patient have coronary disease? What do you think? Very unlikely. Very unlikely. Very unlikely. Yes, exactamente. So, and there's the exercise test of MIBI. Okay, we perform stress imaging because the resting electrocardiogram might be equivocal. You see the LVEF 63%, normal perfusion. So there are two good papers out, one published by Mayo people looking at the outcomes in patients who achieve at least 10 METs of exercise, 9 minutes on the Bruce protocol during a treadmill test. And here's a paper very similar looking at myocardial perfusion imaging. Both of these suggest that outcomes are excellent and ECG changes are unreliable at high workloads and high heart rates. So my second Pearl summary. So number one, use of the exercise test to determine prognosis is neither endorsed nor not endorsed by the ACC and AHA risk assessment guidelines. They would like these tests to be done, but many people don't know how to properly interpret the test, and there's some concern about the added cost of adding an exercise test to risk stratification, but really nothing risk stratifies better than the exercise test. The use of an exercise test for diagnostic screening of asymptomatic patients is not endorsed. So thinking we could accurately detect coronary disease in an asymptomatic individual with no history of disease is not a good idea. And finally, exercise ECG interpretation is unreliable at high levels of exercise and high heart rates. The heart is beating and it's twisting in the chest. We all know that at high levels of exercise and high heart rates, the heart is moving in the chest, and that movement from contraction to relaxation is occurring during the ST segment and distorting the ST segment in that you see that characteristic distortion here is a result of that movement in the chest. The higher the heart rate, the higher the workload, the more fit the patient, the more likely we are to see that. So let's look at our third Pearl.
May I have a word? May I have a question?
Yes.
Could you go back to the stress test EKG?
Yes.
I'm not seeing yet the EKG. Okay, this EKG. Unfortunately, we don't have a voting device here, but I wonder how many of my colleagues would say that this is a positive test in case they have what we call some mild symptoms or not good hypertensive response. Yeah. That's a question, a good point, I guess, because many may say that this is a positive in case they have some mild symptoms.
Yeah. Well, when patients have symptoms on a test, exercise test, one always needs to be concerned and follow that up.
Yeah.
But this guy was asymptomatic, and on a test like this, I usually interpret the electrocardiogram when the patient has slowed down to a walk, and look at the test then. There's so much. So we have the heart twisting, we have the heart bouncing up and down, we have the patient running, a lot of motion artifact to sort through. Here, we might see things more clearly.
Okay.
I have lots of those. I have whole strings of those pearls. Okay, let's look now at the third pearl beyond the Bruce protocol. So this is a 44-year-old endurance athlete, really fit guy, and he's in the he's a cross-country skier, marathon runner, cyclist. He does it all. Cross-country skiing is his favorite sport, and he's going to enter a 50-kilometer cross-country ski race. I don't think you do much in Paraguay, do you? Cross-country ski. He has no cardiovascular disease history. He has no risk factors for coronary artery disease. You see his pooled risk, 10-year risk, 0.8%. Normal cardiac exam, but he's complaining of fatigue. So here's the cross-country skiing, freestyle, what he does, or skating, they also call it. He starts out fine, but in the race, he gets tired. So here's an example, a 58-kilometer race. At 12 kilometers, he's with the lead group. At 35 minutes, he begins to fatigue. He struggles. He stops. He feels better. He starts up again. He feels bad. His time, look at this, 3 hours, 22 minutes versus 2 hours, 23 minutes. He slowed down almost 1 hour from the previous year. Okay. Resting ECG. Has some PACs with a kind of a little unusual configuration. A relatively short PR interval, somewhat prominent voltages, but he's lean, he's fit. Axis somewhat vertically directed. Partly that could be, you remember, when we do a stress test, we have to bring the electrodes from the wrists and ankles onto the torso, which sometimes distorts the axis. So a stress ECG is not really good to determine axis. There can be some minor fluctuations. Now, he did a cardiopulmonary exercise test. This is his off season. This test was done in the summer, but he still had a pretty good VO2 max, a good blood pressure response, a good heart rate response, no symptoms, good effort by the respiratory exchange ratio. We did pre and post exercise spirometry looking for exercise-induced asthma, completely normal. You can see maximal, his oxygen consumption increases normally, decreases quickly in recovery. His oxygen pulse increases normally throughout the test, well above the predicted values. Okay, exercise ECG, heart rate 171, unremarkable ST changes, a few PACs as we had seen at rest. Okay. Doctor, where do you go now? Huh? What do you do? We have failed to reproduce his symptoms with a standard stress test. So we have many options. We could do a 24-hour Holter monitor, but of course it's the summertime, so he can't really go out skiing. We could put a loop recorder in him or on him. We now have wearable loop recorders. EP study really not indicated by the current guidelines at this level. We could perform an exercise test to try to simulate his condition that produced the symptoms, or we could say, everything's fine, maybe this is GI. Well, we did the special exercise test. So we did a non-graded exercise test to simulate his race conditions. 7 miles an hour speed, 5% grade. And then after 25 minutes, we increased to 8 miles an hour or 12.8 kilometers per hour. Okay, now, at 34 minutes of exercise, we see this electrocardiogram. The peak heart rate on the regular test was 171. Now we're suddenly seeing a heart rate of 206. And I think if you look at these R to R intervals, you will see that they are not constant. Now, he stops to walk and very quickly resumes sinus rhythm. A quick heart rate recovery, sinus rhythm is resumed. He goes to exercise again, the heart rate back to 206, and irregular R to R intervals. Okay, so what's our diagnosis? So this patient, which is what we suspected maybe from those PACs, when his catecholamine levels get high enough, and he gets a PAC coming from the area of the pulmonary veins, it triggers atrial fibrillation. Now, is atrial fibrillation, has it been reported in cross-country skiing? Yes. So this is a paper from European Heart Journal, one of the first papers on exercise-induced atrial fibrillation. We see in about 53,000 participants in the Vasaloppet, which is very similar to the Birkebeiner, 681 cases of atrial fibrillation and 119 cases of symptomatic bradyarrhythmias. And you see the faster you skied and the more races you have competed in, the higher your risk of developing atrial fibrillation. So wanting to continue with exercise and competition rather than take beta blockers and or flecainide, he underwent an RF ablation. Here you see a spontaneous left pulmonary vein firing, but there's block to the left atrium, and this does not set off the atrial fibrillation. In follow-up, we performed another exercise test 1 month after ablation, completely normal, and this was our 35, 40-minute exercise test, not the standard one. Last time he was seen in the clinic, now I haven't checked this year yet, so perhaps there's further follow-up, but he's had no recurrence of atrial fibrillation, no complications or side effect from ablation. He continues with full tilt training and competition and high-level finishes in the Birkebeiner. Third Pearl summary. The Bruce protocol is not generally applicable to athletic performance. There is no sport that mimics the Bruce protocol or vice versa. It's important to reproduce a patient's symptoms if possible, and this often requires a specialized protocol. Now, let's go to our fourth and final pearl for the day, beyond conventional risk factors. So here's a 49-year-old man, and he has a recent onset left-sided chest and shoulder pain, but he gets this when he's doing the elliptical trainer. So you worry about, the arm motion. Could this somehow be musculoskeletal symptoms? No family history of early CAD, coronary artery disease. The traditional risk factors, hypertension, diabetes, high cholesterol, smoking, are all negative. And you see his 10-year risk is in the low range. He has a normal cardiac exam. His BMI is 28.5, but in this individual, this is mostly increased muscle mass, not increased fat mass. Resting electrocardiogram. I'll give you a minute to study that. Right? Looks pretty good, but he doesn't do so well. Blood pressure does not get to 160, and in fact, it drops. His heart rate increases okay. Heart rate recovery, not quite high enough. He has ST changes. Performance is poor. He has angina, and his Duke score is -12. And you see ST changes. There's a peak exercise. And you say, aha, Professor, last time you tricked us and you showed us the recovery tracing and they all went away. Well, these don't go away, do they? So here now, 6 minutes after peak exercise, virtually every lead positive. All right. Now, I forgot to tell you something. Do you think this patient has coronary artery disease? Very likely, yes. And this is what I forgot to tell you. He had Hodgkin's lymphoma 20 years prior and was treated with radiation with extended fields. And as you can see, he has an 80% proximal and 60% distal left main lesion. The right coronary artery, which is not in the field, is normal. And here, what is this? Well, they had to evaluate the lima before they used it as a graph. We don't normally have to do that, but we evaluated the lima because it's also in the radiation field. And of course, he goes on for bypass surgery. So the fourth pearl, traditional risk factors do not explain all coronary artery disease. Exertional symptoms are always worrisome and should be evaluated. Chest irradiation can cause coronary artery disease, restrictive lung disease, valvular heart disease, conduction disorders, and chronic pericarditis. And my conclusion, evaluating a patient with cardiac symptoms and comorbidities is a lot like evaluating a used car. And this, of course, is a classic used car. The exercise test is the test drive. Don't even think about buying the car until you take it for a test drive. Is it a Chevy Nova or a Nova? So I thank you for your attention. I hope this was interesting and informative to you.
Sir, thank you very much, Professor, for sharing with us this very interesting cases of a treadmill. There are 4 pearls, one of them that's beyond the ST. And I wonder, in the first case, when to me, I saw a significant ST elevation and AVR. And
well, let's look at that. So everybody loves that AVR, but that's all from the coronary care unit and the emergency room. I haven't seen a paper on people walking around in the outpatient setting because we see elevation in AVR in half the stress tests. Okay, and you look at, there's a lot of variability. Is it true elevation? I don't see any sort of upward coving. Is that J point elevation or ST elevation? And we know that 85% of all the stress tests that are positive for ischemia have ST depression in B5. So I'm very suspicious when I see ST changes and a normal V5. It can happen, particularly in the right coronary. So, you know, that's interesting, but I think I would suggest you go back, and I'm happy to revise my opinion if you show me a good paper on isolated changes in AVR on a stress test. In an outpatient.
Not acute patient. That's right.
But you're correct that ST elevation in AVR with acute chest pain and myocardial infarction signifies a left main lesion. And I think, it's a different scenario. And again, it just has not been valid. Let's look at this one. Here's our guy with completely normal SESTA-MIBI. His AVR, how about his AVR? Looks the same, right?
Yeah, the same.
Here's the, let's look at the skier. Nothing in AVR there. Well, I don't think anything in AVR there. Okay, now this guy, our last guy, well, here now we see some real ST. Look at that. Yeah. So I would agree with you there. That's worrisome, but it's part of a complex of ST depression. And now you see the upward coving of the segments, right?
Yeah.
So here it is very meaningful in this scenario. Here's a man having angina with evidence of ischemia, and you point to this and you say, I bet there's some left main or proximal LAD disease, and bingo, you're right.
You got this case.
All right.
Yeah, very, very nice, very interesting.
I think, again, my point on this is taking the ST segment in isolation, you're losing much of the information from the stress test.
Okay. And also, what we saw in your cases is that the systolic blood response, when the blood pressure doesn't go up, that is a really significant indicator of that something is going on, something structural, or there is a real problem.
That's correct. That's very correct. Now, we often worry too much about high blood pressure on the stress test.
Yeah.
Now, as you see from, let me go back to the data quickly. High blood pressure on a stress test in the short term is not a problem. Now, if the patient has high blood pressure on the stress test, he may eventually get high blood pressure at rest, and you treat it. But as you can see over a follow-up here, the high blood pressure patient, let's see, which is he? Here's the high blood pressure patient. He really didn't do any worse than the
normal blood pressure.
Than the normal blood pressure, okay? Because high blood pressure signifies a strong heart.
Yeah.
And you would treat that high blood pressure, and blood pressure treatment lowers the risk.
Excellent. Is there any question from the audience? Graciela, could you check that, please?
I know maybe Maria Paniagua has a question there, huh? About I know she's an expert in blood pressure.
Yeah. María. ¿Estás conectada, María? Graciela, si puedes conectarte.
Graciela, yeah. All right.
Okay. So far, no question from
Okay. All right.
audience.
Well.
Okay. Professor, again, thank you very much for your time and sharing with us these important, significant cases. We really appreciate it. Again, as you are on vacation, and you too.
I hope one day when you get rid of the COVID, I'll come back and give you a talk in person, and we can go to Chaco, huh?
Yeah, and you know that I owe you that trip to Chaco.
Yeah. Well, and I'm sorry I haven't been there yet, but now my schedule's a little more relaxed. I'll have time to do that, and they'll hope that next year we only have to worry about the jaguars and the snakes and not the COVID. All right,
and the whiteboard. There are many whiteboards.
Yeah. All right.
Okay. Thank you very much again, Professor.
All right.
I'm sure I'll take you to Chaco.
Bye-bye.
Thank you. Okay, bye-bye.
To bebé tai sarambi pelveture Shenye agui anyandu va pura hei To putanye epote de yurupe Hapuka vupe se anyua Rei potaro e yerurente Peisajina Paraguay Paipuque la Emiliano ta ipuque la Yambay Yahamino nyondive yero krehape Torbu ape yahesape koe Aguille manteame Hagueruko senye Toiko subi pura hei Halbu arito bebe Aguille manteame